Hello, everybody. My name is Joseph Mccoy with High Tech Associates, and thank you for attending today's webinar on information blocking. Information blocking is a newly implemented law that will bring substantial changes to the way your practice conducts business. This webinar focuses more on how to implement practices to become compliant with information blocking. If you have any questions, please post them in the chat and they will be answered at the end of the webinar. Today's speaker will be Michael Mccoy, our senior security expert. With over 10 years of experience, he has been on top of this new law since it was passed. Please welcome Michael Mccoy.
Good morning, and thank you for that, Joe. Right now, I'm going to put everybody in a mute so that we don't get any interference. But again, put your questions into the chat box. So do not block access. Information blocking is part of the 21st Century Cures Act, which is Section 404. And again, as Joe stated, there are going to be substantial changes to the way you do business. In fact, the ONC has described it as a tidal wave of change. So why information blocking? Why new rules and regulations? Well, a major component of this rule is the immediate release of health information, including but not limited to clinical notes, laboratory data, imaging and pathology reports, immediately to the patient and also to other providers. The goal is very simple. It's about access and choice for the patients. Patients should be able to access their electronic medical record at no additional cost. There are also advantages for you as a provider. Part of information blocking will make it easier for you to switch and use the best EMR for your practice, and we'll go over how that's going to be accomplished. So whether you look at information blocking as an opportunity or a burden, you're probably going to see it as both. In one way, patients are going to be able to access their patient information without any effort on your part. So as more patients move to a patient portal and use that, you have less burdens in your medical records department. And the overall design is to make sure that there is complete transparency. Eventually, your cost and other information will also have to be shared. And it's going to be in what they call new and novel modern ways. And basically, the end result is that all the patient information from all of their providers, all of the hospitals, labs, radiology facilities, will be available to them on their smartphone. And then there will be complementary apps. And these apps will allow for them to track their blood sugar levels, their heart rates. All of this information is designed to work together seamlessly. But to do that, they had to implement this information blocking rules and regulations. Now, what you're looking at now is the timeline, and the important date here is April 5th, 2021 is when the information blocking rules and regulations became effective law. And so it is currently law. All of the things we're going over today are required per this. Now, a little bit about how this came about. In 2015, the Congress asked the Office for the National Coordinator, the ONC, stating that our constituents have been telling us that they are having problems getting medical records from their physician offices. Physicians were complaining that other physicians would not release notes to them. So from that report, they came up with the 21st Century Cures Act, which was passed in 2016. It's been since then that they've been working on Section 404, these information blocking rules and regulations. Now, I like to remind everybody that this is something that's unusual in Washington. It's a bipartisan bill. I often get questions, when the next administration comes in, are they going to forget about this or not enforce it as much? No, this is a priority for all of the administrations that come in. And when listed in Health and Human Services top priorities, this ranks about number 4 of their top priorities. And you've got COVID and some other things on top of that. So very, very high on their list. Power to the patient. Our records, our right, our choice. That was tweeted out by the Deputy National Coordinator for ONC, and that's basically what it is that they expect, that patients are going to have better outcomes because they're going to have more information. So this is going to require substantial operational and cultural changes within your practice, especially with some of the doctors. The regulations go from you can share under under HIPAA, you're permitted to share, to information blockings, you must share. And it's based on the request. And the request is very broadly defined, as is the rest of information blocking. So a patient going to their portal, that is a request for information. Now, I want to go over real quickly the government agencies that are going to be involved, because this is a whole Health and Human Services effort. So Health and Human Services is the overall agency. Underneath them is the Office of the National Coordinator. They have been tasked with implementing and writing the rules and regulations and putting out the guidance. And they have put out a ton of guidance, many of it misleading. We'll kind of go over some of that today. Office of the Inspector General. This is the agency that enforces Medicare and Medicaid fraud. They are going to be investigating claims of information blocking. Unlike the OCR, the Office for Civil Rights, who enforces HIPAA, they put out about 30 investigations per year that are publicized and where fines are attached. The Office of the Inspector General can do 30 a day, and they put out a list that we receive. They are much more part of making sure that enforcement is done. So we expect to see a lot of enforcement. Again, OCR, HIPAA is still alive and well, so we're still going to be talking about the Office for Civil Rights. And part of information blocking does also involve Medicare fraud. So the CMS, Centers for Medicare and Medicaid Services, will also be involved with this. And even though they're not a part of Health and Human Services, the Federal Trade Commission, we've seen an increase in their activity in healthcare, and all they have to do is determine that you are not following information blocking. That is an unfair trade practices, and you can come under their jurisdiction as well. So there's going to be a lot of enforcement. We really want to make sure that all of the offices get fully ready for this as it's put into place. So you've heard the term interoperability. This is the key of what they want to do. Is the government spent billions of dollars getting almost every doctor's office and hospital on electronic medical records. Now, the EMR companies came up with an idea that even though they had to use a standard called HL7, they would make different flavors of it so that if you're on Athena, you cannot easily move your patient information to eClinical. You have to pay interface fees and all these other fees. So part of what this is going to do is change that, because, and you may already be familiar with the FIR standard. It's a FIR HL7, and it is a standard format for data exchange. All of your EMR companies will be changing your systems to this new standard, or they face substantial penalties. So there are going to be changes there. Now, things that we're not going to be talking as much about today are what's called an API, an application programming interface. Think of that as an app on your cell phone. You go and get your banking information, that's through an API. The other thing, and this is going to be something, again, coming down the road, not today. Well, I've got actually one practice that's already had to do this, but you're going to find out that there's a TEFCA. What is that? That is a Trusted Exchange Framework and Common Agreement Network. Part of information blocking states that you will have to join these networks. I'll talk a little bit more about them later in the presentation. But interoperability, that's the key word. And the other key word is going to be interference, and we'll go through that. So right now, there is enforcement of information blocking, but not to healthcare providers. So to be under information blocking, you are considered an actor, and there are 3 types of actors. The other actors are going to be the certified networks and the certified developers of health IT. Today's, we're going to focus on your practice, so we're talking about you. Now, The other types of actors have civil monetary penalties already in place. Those penalties are $1 million per violation. And each information blocking claim could have multiple violations. So the thing to take from this is the penalties are going to be severe. They are designed to be severe so that nobody can be an information blocker. Right now, the law calls for appropriate disincentives for healthcare providers. Those have not been published. But here's another thing to consider: harm and damages. So if you block information to a patient and you say that there's no harm or no damage, we got it done in a manner that may have been information blocking, but there wasn't any damages, that does not alleviate you from being an information blocker and having appropriate disincentives placed. So this is the advantage of what's going on right now. The law is in effect, but there are no penalties. As of today, because they have not been published what those appropriate disincentives are going to be, there's no teeth to this rule. Now, what they told us was that they had been postponing the implementation of information blocking because of the fact of COVID. But now they decided that April 5th was going to stand because they did not want to delay it anymore, but to give everybody time to get their practice updated, policies and procedures, training their staff, getting everything in place, they basically have put a law out there without teeth. Once these appropriate disincentives are published, and we've heard that they could be as much as a year's worth of your Medicare and Medicaid reimbursement. So again, they will be very severe when they come out, but once they get published, you'll have 60 days. I expect that by the end of the year, they will be published and enforced. So again, you've got a couple of months here to get your practice ready. So again, I told you that you are an actor, and healthcare providers are treated a little bit different from the other actors. But if you have anybody that comes into your office that you call a patient, you are probably a healthcare provider under information blocking. Even if you are not a HIPAA covered entity. So if you are a cash only practice, or for some other reason are disqualified under HIPAA, you would still be covered through information blocking. So do understand that you are going to be a covered entity. Now, this is something that we've had from a couple of our clients. They've called us up and said, listen, we heard about information blocking, but our EMR told us that they are not an ONC certified developer. And since we're not using an ONC certified EHR, we are not subject to information blocking. They could not be farther from the truth. It doesn't matter whether you're using a certified health IT software. It only matters that you meet that definition of being an actor. So the definitions basically that you need to know are EHI. What is covered? At least until May of 2022, EHI is defined a little bit more narrowly, and we'll go through that in the next slide. But the definition of interference is if you interfere with access, exchange, or use. Those have the common definitions that you would expect them to have. So under information blocking, again, until May 2nd, 2022, they're using a standard called the US CDI version number 1. This is what you are responsible to provide under information blocking. So it's not PHI, protected health information under HIPAA, it's a limited set of that. It will become PHI after May of 2022. So, but here's the things that it does include: your assessment and treatment plans, laboratory tests, clinical notes, goals, health concerns, problems. Now, again, right now, when it comes to radiology, it's only the narratives, the reports. The images are not required to be shared until the May 2nd deadline. So do understand that the other thing that's not included is billing and payment information. We don't see anything about that on this US CDI. So those still are going to fall under HIPAA. It's not that I don't have to do them. I just don't have to follow the information blocking rules and regulations. I still have to apply to HIPAA. I do want you to know that right now HIPAA allows you 30 days. So if somebody asked for their billing records, you would have 30 days under HIPAA. But there's a proposed rule that we expect to go through that will lower that to 15 days. So these are the elements that you must be able to share and that your EMRs should be making sure is shareable through the patient portal. Again, HIPAA is the backbone of the information blocking rule. Information blocking does not create any new access rights or remove any of the HIPAA protections that are in place. And state and federal law restrictions and requirements are also unchanged. So basically here, what we're doing is increasing the ability to access and dramatically reducing any burdens and delays in the patient getting access to their medical records. So what are some of these state and federal laws other than HIPAA that are applied? Well, minors' rights. If you are a pediatrician's office or you have any pediatric patients, they may ask for the privacy right not to have their information on their sexual health shared with their parent. And so that's something that is still in place. So again, everybody doesn't get access just because of information blocking. We still have to follow the HIPAA and federal rules and regulations. And of course, substance abuse information can also be withheld. Information compiled in reasonable anticipation of a civil or criminal act or administrative proceeding. Again, under HIPAA, that's your right. Now's when I want to spend a little bit of time on psychotherapy notes. We have a lot of providers that we work with that can't get this done. And I'm going to tell you under information blocking, you better do what is required. And, as soon as you get off the webinar, I would get started on this. Psychotherapy notes are defined as the notes recorded by a healthcare provider who is a mental health professional or documenting or analyzing the contents of a conversation during a private or group counseling session. Typically, they're written down, but they may be digital these days, but they have to be outside of the designated record set for the patient. So if they are in a folder in your EMR, and it's just a different folder that says psychotherapy notes, that is not outside of the designated record set. The law says they don't get this special protection. So psychotherapy notes must be kept completely separate. The only way that psychotherapy notes can be released is with the patient's signed authorization and they're being sent to another therapist. So the patient's representative, other non-therapy providers are not allowed to receive those notes. They're basically considered the private thoughts of the therapist during the session and not a part of the medical record unless you put them in and make them part of it. The other way that you can release them is not with a court subpoena, which is signed by an attorney, but a court order signed by a judge. So you see they have very special protections to keep them out of anybody else's hands. Now, a lot of the practices say, well, what's the problem? If we leave them in there, well, one, a patient request for their records, you would have to release them. I can almost guarantee you that the therapist does not want that patient to see those private thoughts and opinions that they wrote during the session. They could also be released to an attorney via just a regular court subpoena if they are not separated. And then you're going to be subject to lawsuits based on the failure to provide your HIPAA legal protections. It's actually in the definition in the law that the psychotherapy notes must be kept separate and apart from the other records. So there are different ways to do this. If you have problems with figuring it out, please call us and we'll give you some of the different ways to do it. If they're in paper, that's a great way. Just keep them in a paper folder. I know we're trying to get away from paper, but it may be a good alternative. Or if you have remote, and there are a lot of therapists that are remote, then something like ShareFile allows the therapist to see only their records, but the home office to get all the information they would need for billing and other purposes. So please call us if you need more information on that. So again, a quick review under HIPAA, and again, HIPAA still applies. those psychotherapy notes, the request for records that can be denied if the patient is part of a research and that research is still ongoing. If you have patients that are inmates, you may be able to keep the information from them in copies, but you would still have to give them the right to inspect their information. And again, if there's a Privacy Act request or there's a Privacy Act proceeding, you can deny patients their records if the administrative agency has asked you to do so. There's also a time that patients, family, and friends may give us information under the promise of confidentiality. And HIPAA still applies, so that if a parent or a family member gave information on the patient, they didn't want the patient to know that they provided this information, that can be withheld. We're going to see how that's going to create all kinds of problems under information blocking. And then there's also the reviewable ground of the medical professional feels that the request is reasonably likely to endanger the life or physical safety of the individual or person. That is a grounds that you can deny access to the patient records. I want to point out here that it's physical harm. It does not extend to psychological or emotional harm. The patient would get upset if we gave them these notes, does not meet even the HIPAA requirement. So as I said earlier, interfere is the key word here under information blocking. And so except as required by law or covered by one of the exceptions that we'll go over, is likely to interfere with access, exchange, or use. Now, this is directly from the ONC. We interpret interference broadly and to take many forms. Any delays could be considered information blocking. Any charging for patients of access to their portal would definitely be considered information blocking. So the legal elements, first, you must be an actor, so you have to be one of those healthcare providers that we showed earlier. Knowledge, actor must know that the actions are likely to interfere. So here's kind of a little loophole one, but ignorance of the law is not going to be an excuse. Intent, so you have to intend to information block. So, but the definition there is that you did something that was unreasonable and again, likely to interfere. Again, remember that the legal element for the first 2 years or year and a half is that EHI has to be defined as part of that US CDI. The disclosure is required by law and it doesn't meet any of the 8 exceptions that we'll be going over here today. So again, substantial operational and cultural changes. For nearly all EHI requests, you must respond. Under HIPAA, you are permitted and allowed. Now you are required. And again, the timeframes are very, very close. Now, if you prevent materially discouraging a patient from accessing their medical records, so you really don't want to do this, you don't want to go through all that, it's not going to be a good fit for you, that could actually be considered information blocking, just trying to discourage a patient from using the EMR. Now, here's another one that we've gotten recently. Our practice doesn't have a patient portal. I was actually talking with a client yesterday and they told me that to add the portal to their system, they're a large client, but the portal comes with other add-ons that you cannot separate out, and it would cost them $250,000 to implement their patient portal. Is it worth it for them to do that? Well, here's the problem. You are still going to be covered under information blocking if you do not have a patient portal in place. You're going to need to be ready, your practice is going to be ready to provide the requested information in the method requested, which may not be available due to the fact you don't have a patient portal, and without delay, or you're going to have to cite exceptions. That means if you do not have a patient portal and the patient asks for it, you're going to be filling out 4 or 5 forms for every single patient request so that you can document properly your denial of access through the patient portal. So I really do not see as not having a patient portal as an option, at least not one that you would not have to hire additional staff to be able to comply with this rule and regulation. So from the ONC's own documents and guidance, here are some of the practices that are considered to be information blocking. So again, anything that restricts authorized access and doesn't meet an exception or violate a federal law. Implementing health IT in non-standard ways. This is really for the EMR companies that if, again, they all made a different version of HL7, that is no longer going to be allowed. That's going to be a benefit to you. Limiting or restricting the interoperability of health IT, such as disabling the sharing of any of the records. So this isn't only the disable, this is, I can't partially open up my EMR and be compliant with information blocking. Inaction. So, well, the law came into effect, but we didn't go in and modify our portal to give patients more access. That could also be considered information blocking. As I stated earlier, acts that lead to fraud, waste, and abuse could be considered information blocking as well. And again, it's the Office of the Inspector General who enforces Medicare and Medicare fraud that will be doing the investigations, and that's definitely not something that you want going on there. Restrictions on any access expressed in contracts. So here's where you're going to be spending a lot of time. Every single one of your service agreements, every single one of your business associate agreements are going to have to be reviewed for information blocking. In other words, if my business associate agreement allows my medical records management company to provide patients their records in 5 days, that alone, whether it ever happened or not, just being in that contract is information blocking. So you are going to have to go through and review all of your current business associate agreements and service agreements to make sure that there are no delays written into them. And just from experience, most of them do have some form of delay where they have a certain period of time to provide you with patient records, and that is not going to be permissible under information sharing. So you have to get those updated. I also know that Greenway's one that are sending you new BAAs, and there's really only 1 or 2 lines different. And basically it says that if you block information through the portal to any of our patients or any patients that you have that are on our Greenway system, you must report it to Greenway. Why do they want to know? Because they could be fined $1 million per violation. So you're going to have to read these updated agreements as well to see what you're required to notify them of so that you don't get into trouble there. So some of the formal restrictions are a policy that says that we're not going to share any patient information to another provider without the patient coming in and signing our authorization. Hipaa says that that's a permitted disclosure. So it is permitted by law. So if you require that authorization, then you are information blocking. Now, we're going to talk about the exceptions, and one of those may be for privacy. And we'll talk about how you might apply the privacy if we didn't know that Dr. Jones' office is a part of the continuity of care for this patient, and we want to take a reasonable amount of time to verify that this is somebody that the patient is sharing information with as a part of continuity of care. Providing information in an unusable format. So I've got offices, they only supply the patient records on a CD. Well, the patient says, I don't have a CD reader on my computer anymore. You would be guilty of information blocking by not providing it in a usable format. Again, disabling any of the interoperability. The doctor doesn't want to share this information with the patient. That is no longer allowed. The patient basically now owns the records. You are the record custodian. And here's where an isolated inference could be a part of this. And again, we really are waiting to see how this is truly going to be enforced. But again, I expect it to be very strict based on their priorities and statements. But if you have the capability to provide same-day EHI access to another provider. So the referring physician calls you as a specialist and asks for the information, or the patient calls you and asks you for that information. Your staff could have gone, it's in the electronic medical record, it could have been done that same day, but it took you 2 days to respond. That could now be information blocking. So patients, much easier because of the patient portal. But what about those other providers? We don't have a portal system readily available to say, Dr. Jones' office, when you have a patient that's also one of our patients, you can come in and just pull those records. That is going to happen, but currently I see more complaints being filed by providers than by patients. We still do not see a lot of patients using the patient portal. Nationwide, I just saw a survey that said it's about 15% of patients. The offices that we work with, I would say it's closer to 1 to 2% of the patients actually use it, but you're still going to have to implement all of this. Inherently suspect activities, things that you're going to have to really prove are not information blocking, is any interference with the patient seeking access to their own information. Providers, again, seeking those medical records for treatment or healthcare operations. What about all those pesky insurance third-party companies that want to come in and check my records? Information blocking if we don't give them quick and easy access. So I know a lot of you do not want to give them a user ID and password to remotely log into the system. If we don't have a good exception or reason not to that we can document that meets the requirements, we're going to have to start doing that, which again is going to be more work on your part to enable and disenable those usernames and passwords, to do audit checks after they come in. So we're going to have to figure out ways to accomplish this within your office in a safe and secure method. So some examples of information blocking. Again, having an office policy that is more restrictive than HIPAA. Requiring that authorization for continuity of care is a perfect example. But again, I may be able to apply the exception of privacy or security. We'll talk about more about that here. Creating hurdles to the access or exchange. So again, making sure that if our system is capable and we get a request, that we do not disable any interoperability. Misunderstanding the law is another example that the ONC put out. So again, you're applying a HIPAA claim to restrict disclosure when no HIPAA claim actually exists. So you may want to check with us or with your policies and procedures before applying a HIPAA restriction that you may be unsure of. Slowing or delaying the results. Now, here, there are some states. Now, I've done a lot of research. I can't find any, but I have heard that there are some states that allow you to delay a pathology or a lab report until the physician has had a reasonable time frame, maybe a day or 2 days, to actually review the information before it goes to the patient. In the state of Florida, you do not have that. Taking more than a day of having records would be considered information blocking. So just because the pathology report comes in and tells the patient that they have cancer does not give you a valid reason to delay that result going to the patient portal. Not entering data into the EHR in a timely manner is also going to be considered information blocking. One of the bad things is that the ONC has been asked, would you tell us in advance if we are information blocking, if we give you the circumstances? And their answer is no. You're going to have to go through an Office of the Inspector General investigation if we suspect it. So do understand that there are lots of ways that we can be information blockers using other time frames provided by other laws. So under HIPAA, you have 30 days, maybe soon 15 days, but you cannot use that. Information blocking now makes the standard immediate. And again, provider to provider request, not permitted anymore. They are directive and required. Physician who wants to review the records before releasing them. This would constitute an unreasonable delay. Now, here's where it's going to get really tricky for some of your physicians that like to do all of their notes and then sign off on them during the weekend or a week later. Are draft notes required to be shared with the patient? Yes. So before the physician signs off on them, the patient could go to the portal and review them. So again, substantial changes may need to be made in your office so that draft reports aren't being released to the EMR. Test results, if requested, as soon as you receive them. And if you do not have the technology, this is going to put more work on your staff. So do understand that the patient should be receiving information at the same time your office is. So again, if you have the capability to push this to the portal and you don't, you better have a good reason and it better be documented. Now, here's where information blocking is going to get very expensive. Not interfacing with certified APIs, these applications that allow patients to get their information via a cell phone, and these trusted exchange networks. So we've had one client be approached by a network, and to join their network, they had to pay a $9,000 fee just to interface and get put onto their network, an onboarding fee. Their monthly fee is $450. And then there's also a transaction fee for every document that is uploaded and downloaded. I can guarantee you that none of you want to pay these network fees. But if you do not, you are guilty of information blocking. So the choice comes, do we lose a year's worth of Medicare and Medicaid every year that we don't join? Or do we pay these fees? When I called this network, even for small practices, a 1 or 2 doctor practice, it was a bigger practice, they still estimate that the onboarding fee is going to be about $4,500. The monthly fee is $2,250, and you still have those transaction fees. So this is going to be expensive, but think about it. How are the APIs, the Google Health, Amazon Health applications on a cell phone going to access your network? They're going to have to connect to these networks, and you're going to have to connect to the networks so that this is all a seamless sharing. Now, I expect probably by the end of the year, next year, that's when we're going to see these networks coming to you. But a good example is if you're in the greater Tampa Bay area, Nuance PowerShare. Nuance PowerShare has come on board. They have TGH on board, they have Advent Health, they have Baycare, and they have HCA. So you would not have a valid reason not to join. So these are things that we'll be putting more information out about because we see them more in the future. We're more focused on patient portals and other requests for continuity of care. Again, contractual restrictions, go through those BAAs and service agreements. And again, discouraging a patient from accessing their medical records, that could be considered information blocking. So again, a slide here on going through and making sure your agreements with your business associates and vendors does not have any information blocking provisions. Again, anything that would restrict access from days must be changed to immediate. So there are going to be challenges. I think I've brought up a lot of them here, but again, that's why it's a good thing that the penalties are not enforceable right now. There's no teeth to the law, but again, by the end of the year, we expect to see significant teeth. So pediatrics, you have patient privacy requests that are allowed by laws. If the parent, personal representative wants access to that patient's portal, how are you going to segment out their sexual health information? You're more than likely not able to do that. So we're going to have to go to the exemptions and go through and apply those, and we'll get to that in the exemption sections here. Again, those contracts, review them. Scanned records. Can a patient through the portal get access to scanned records? Many of the EMRs that we've worked with do not have the capability to show records that you've scanned in, maybe from another provider, maybe lab results or something else. directly to the patient. So how are we going to get around that? And again, lab pathology reports and imaging reports, not imaging images, must be available for immediate reporting. And again, how are you going to segment out notes that are told to you in confidentiality when the patient wants access to their portal? That's going to make it extremely difficult for you to do. And so you're going to have to deny them portal access and come up with another way of providing that. Now, we do have a few pathologists that are part of this webinar today. So I did want to point out that for pathologists, pretty much if you are allowing the finalized result to go in a reasonable time to the physician and to the patient, you're not going to have to change any of the things that you're doing. Now, again, you are not able to delay the release of this information until the ordering clinician has reviewed it, unless there's a state law that says that you must do that. Subtest or pretest are not included. Only the final report is part of information blocking. So if we did some subtest or pretest before the final test, that's a part of Hipaa, and the patient could request that under their Hipaa rights of access, but it's not a part of the US CDI and therefore not a part of information blocking at this point. So do you have to answer phone calls from patients to take their information? No, and the main reason there is that's not a reimbursable. So as a pathologist, you are not required in information blocking to take those phone calls. Now, I told you that the ONC has put out a lot of information on information blocking, and some of it has been misleading, and this is a good example of that. So one of our clients sent me this exact slide. Do the information blocking regulations require actors or healthcare providers to proactively make health information, EHI, available through the patient portal? Their answer is no, but that's not really correct. And so the ACR, American College of Radiology, put out this article basically saying what's going on here, because that's not the way we understand it. So the ONC clarified it and put out this additional FAQ to basically illustrate what interference would be, where a delay in providing access, exchange, or use after a patient logs onto the patient portal to access their EHI, including lab results, and such EHI is not available for any period of time through the portal, could be considered information blocking. So the answer is yes, you must proactively push all of the US CDI information to your patient portal. So key conditions. One, you cannot have a blanket exemption. You cannot write a policy that says we're not going to share records until a patient signs an authorization, even for continuity of care. That's a blanket exemption. And under information blocking, it has to be tailored case by case, and it has to be in a consistent manner. And there can be no discrimination. We can't favor one vendor or provider over another. And it should be based on our written policies, or again, we're going to have to document that case by case determination if we deny access after a request. Reasonable effort must be taken to fix or correct whatever problem caused the information blocking. And of course, it must be fully documented. We're going to show you how we've made that much easier for your practice. So more exemptions, or so the exceptions. So the exceptions are out there. There are 8 of them. This slide is basically showing you what has to apply to all of them. So this is kind of a general test before you can apply any of the exceptions. So it must be reasonable and necessary. It must address a significant risk, and it has to be subject to very strict conditions. So in other words, we have to tailor it to exactly what we have to deny and then apply or give the patient or the other provider all of the records that we can. So it's not just a blanket exception. And again, we have documentation requirements to the patient. to report to them why we denied their request. So preventing harm is the first exception. And again, this follows Hipaa. So if the access requested is reasonably likely to endanger the life or physical safety of the individual or another person, that could be grounds for denying access to that patient. Again, remember, this is physical harm to the patient or someone else. This is not psychological or emotional damage. That does not rise to the level to be preventing harm exception. And again, what we have to document, and each one of these under the law, and that's why we've created a different form for each exception. So here for preventing harm, is there a reasonable belief? The actions we're taking are no broader than necessary. Maybe we keep some information out, but provide the patient with the rest of the information. Again, we're not going to be able to do that through the portal because we can't segment it. So we're going to have to add another content and manner exception and fill out another form. So again, this is a burdensome law. I've had many attorneys tell me that this is the worst written law that they have ever seen come out of Washington, and I think that's stating a lot. But it's what we're left with. So again, we can comply with it, and we want to make sure that we make it easier for you to do so. So what is the type of harm? What's the implementation basis that we've done there? The privacy exception, again, under Hipaa. If the patient has requested, I don't want my parents to get my sexual health information, or I have told you in confidence about a condition that my wife has that I don't want her to know, then I have the privacy exception. Again, we have the privacy exception form. I want to go through, and that's why we've created this form for you, to make sure that we document what the law requires that we document for this exception. Security exception, also again, an important part of Hipaa is making sure that the information is kept safe. So if a API, a app developer comes and says, we want to interface with your system, and if they're an ONC certified, then you're going to have to accept that they have been certified for security, and you're going to have to accept that. But if they are not an ONC certified, you could review it, and documenting it, we could say that we don't feel that the security is there, and therefore we are denying access to this interface, and that would not be information blocking. So again, documenting in detail is critically important. Content and manner exception. So here's an exception where that patient who doesn't want their sexual health information shared with their parent, so we're going to have to do content and manner. We can't provide portal access because we have no way of segmenting it out. So we're going to negotiate, is actually their word, with the patient personal representative and determine, do they want it on paper? Can we give them their records on a CD or thumb drive that would have the information that we're allowed to share? Because again, it's not a general exception not to give them any information. We're still going to have to do it. So again, more work on your part, case by case determination here as well. So again, we have the form for you so that you can logically walk through the requirements. Health IT performance exception. So now a certified API has come to you and said, we want to have access to your network so that our patients that have our app can access their medical records. And you go ahead and because it's certified, you install it, but now it's causing a significant drain on your IT performance. Your entire system slows down. It's using up all your bandwidth. Well, now we have a health IT performance exception. Adding this is hurting the performance of our EMR to our other patients and other needs. So we can now block that access because of this reason. And again, the form to document and go through there. And we would want to, again, make sure that this is implemented in a consistent and non-discriminatory manner. We can't favor one app over another app and make those type of determinations. That would be considered discrimination. The Infield Feasibility. So again, it will not be information blocking if you cannot do the exchange or access because it's just infeasible. We just cannot provide it in that manner. So the infeasibility may be that the system is down, that our system, our patient portal over the weekend is being upgraded and patients would not be able to access the portal. We're going to use the infeasibility exception, but again, that's going to be for a very limited time. We're going to, again, have to document it through the process and send the patient the letter explaining it. There are also other exemptions or exceptions, fees and licensing. Those are really designed for the ONC Health IT performance or Health IT developers and the networks. It kind of says that you guys have to work together, and if you can't come to a final agreement, there are some ways for you to get out of having to share information with each other. So again, we also have in our information kit that the letters, again, with all the other forms, if I'm denying it, this is a quick and easy letter that I can send out within 10 days explaining why we've denied it and that, we can share some information, but not all of the information, whatever actually pertains to that case. Patients' education. Something that we've seen consistently from the OCR is that they expect you to educate the patient on this portal access. They tell us that there are many times when an elderly patient gave their username and password to their son and told the son, I want you to check my medication list to make sure it's up to date, but did not realize that now that they gave out that username and password, that the son had access to their full medical record, not just the medication. So they want you to explain that to your patients. They also want you to tell them that, hey, anybody with that username and password is going to have full access to your medical records. So again, we've developed a quick and easy form that will meet those training requirements to the patients. So suggestions from the ONC on getting ready. And again, this is a quote from the director, Mccoy. Interoperability is a priority which will require operational changes. I think you've all heard about that today and understand it's not going to be easy, but again, luckily we have time in how information is shared. So how is your portal configured? What capabilities do you have? Well, you're going to want to perform an information blocking risk analysis. It's in the kit. If you're one of our clients, we will be doing that when we perform your annual Hipaa risk assessment. We're also going to be doing the information blocking risk assessment as well. The questions are also in the kit so that you can do it yourself. And it's a good way to walk through and see where are we, what do we have to do, where are we going. Updating your policies and procedures, not only new ones for information blocking, but also your Hipaa policies and procedures. And we have those that we're going to be making available, their patient access to medical records. All of those have already been updated, and we just need to get those out to you so that you have those in place. Again, reviewing your current policies and procedures. If you're using ours, everything's going to be updated. Reviewing those business associate agreements and service agreements, and finding out from your EMR, where are you guys at? They have a couple of more years to get everything compliant. That timeline that I showed you earlier, before they have to be fully on that new FIR HL7 standard, they've got till the end of 2022. But what improvements have they made to the portal? Maybe to get scanned records available to the patients, or other ways that we can increase access through these networks and to our patient portals. So make sure you've got an action plan. Make sure you've got the exception forms ready, because again, the law is very specific as to each exception. One of the things that we're going to be doing and putting into the kit is little bite-sized chunks. So you don't have to watch the full hour and a half training on information blocking. You'll be able to go in very small bites. I need to do a form for an exception, and you'll be able to have a quick example of filling out that form and going through it. Training, again, not as much training for your staff, unlike Hipaa, but they are going to need to be made aware of what information blocking is and how we are implementing it within our practice. And then, of course, as the compliance officer, you're going to need to make sure. There are going to be a lot of updates to this kit, mainly because, again, it's on paper, but it's not been enforced. We don't know exactly, what's going to be happening, and we'll be updating and defining everything as that comes aboard. So I'm going to open it up to questions now. Let you know that we do have the kit available. You can go to our www.HIPAA compliance kit. It can be ordered through Amazon, and very soon we will have our infoblocking.net up as well. So again, do not block access, and it's going to be very easy to report it. They put together a portal at the ONC, and all I have to do as a patient or another clinician's office to report you for information blocking is go right here, fill it out, and now you're going to be on the radar of the Office of the Inspector General, something that you definitely do not want to do. Okay, so I do see we've got a couple of questions in chat, and I'm going to unmute everybody as well so that I can speak over here with Joe as he goes through these for us.
Okay, so we have two questions. If anyone else has any questions, feel free to write them in the chat now. So Paige asks, to confirm that request through patient portal applies to info blocking. If a patient calls and asks for medical records, we still get the HIPAA allowed 30 days to comply.
And that is a no. If the patient wants their records through the portal, then we have to provide that instantly. If they want their records in paper or another format outside of the portal, then HIPAA would apply, and we would have the 30 days if it falls outside of the US CDI. So again, that's where we really don't know how they're going to enforce it. Does that mean that a patient's request for paper records also has to be immediate? I don't think it's going to have to be immediate, but I think it's going to have to be within 10 days. Taking a week or 10 days, I think, could be considered information blocking, even though HIPAA allows you that time frame.
Okay, and then the next question is, how can we combat highway robbery from these API type companies? Who do we write or call?
Okay, another great question. Joining the apps is probably not going to cost you anything. They're going to want to join. It's the networks, and that's going to remain to be seen. I could complain with the Office of the National Coordinator that I feel that these fees are unreasonable and too high, but it's going to be the Office of the National Coordinator who will do that. But again, the fees that I've seen, I thought have been pretty excessive. But again, you're going to be required to join them. So it's the ONC that will take that up with. And by the way, yes, everybody will have access. We'll be putting this PowerPoint up on our website, the HIPAA compliance kit for now, and then also on information blocking. Probably by the end of next week, that will be fully up and operational, where you can get not only the kit, but also the slides and a recording of this presentation today. We do please ask.
Thank you for calling the office of Dr. Howard J. Gelb, MD. We are located at 9980 North Central Park Boulevard, Suite 222. Our office is adjacent to the West Boca Medical Center on Route 4.
Okay, got that one off. Sorry about that, everybody. But send this out to other administrators and office managers that you know, because again, this is our fourth webinar on this. This one was a little bit more detailed and into it, but we've still not seen a lot of interest in this. And again, this is going to have a major impact. We don't want you or any of the other practices out there going through that Office of the Inspector General investigation. Okay, Joe, do we have any other questions?
Yes, we have a few more. Will it be considered information blocking if you do not have outside provider records on your patient portal available for the patient to see, or will it be only specific to your records only?
Very good question, and I should have brought that up. So this, like HIPAA, involves all patient records that you've got on file. So whether you created them or whether they were created by another office, if you have them, they are now part of information blocking. So yes, you are going to have to share other providers' records that are in your EHR as well.
Okay, next question. What does a psych practice make available? Nothing or summaries?
So again, the only thing under the law is the psychotherapy notes, again, defined as the notes by a therapist or mental health professional during a counseling, either group or joint or individual. So those notes, those are all that's included: medications, treatment plans, progress notes. All of that is fully available to the patient under information blocking and Hipaa. It's just those specific notes taken during the session.
Okay, and then the last question so far posted is, can you repeat what to look for in our current BAAs now?
Yes, so your current business associate agreement may have a provision that, say you're using a records management company or a billing company. And in the agreement says that if a patient requests their information, we are allowed to respond within 10 days. That is information blocking just on its own, whether it happens or not. So that provision would need to be changed to that if a patient requests their information, it will be made available immediately or within a reasonable time frame. And that reasonable time frame, from what we've seen defined by the ONC, is 1 day or same day.
Okay, another question popped up. How long does a provider have to review studies before it is considered blocking?
0 seconds is the simple answer to that. So as soon as it's available to the clinician, it must be available to the patient. So again, if the doctor does his notes during the day but doesn't sign off on them until the weekend, he cannot withhold them. When a imaging study narrative or a pathology or lab report comes in, it must be made available immediately. So at the same time you have access, the patient needs to have access. Again, I understand that doesn't sound right. I shouldn't have a patient on a Friday, Memorial Day weekend getting a pathology report that says they have cancer and then not being able to tell the, talk with the patient until next Tuesday. I agree, that's probably not good patient care, but that is the law.
Okay, follow-up question to that one. Our provider reads her own studies, so this means that she had to read her studies immediately after they are performed.
So she reads her own. No, there's still a reasonable time frame from when the study is done. Say for even a pathologist, I don't have to be right on top of every single test as the result comes out. But you probably have a reasonable time frame within your office. And so if the study's done that day, the doctor gets them the next thing in the morning and completes them and signs off on them. That's when it's signed off on. That's when that study's going to have to go to the patient portal.
Okay, another question. What if physicians are using a dictation system and do not dictate on date of service?
Okay, so here, that dictation is not part of the US CDI. So when the report comes back in, it is a draft report. That's when it has to be made available to the patient. So even before the clinician has had an opportunity to review it and sign off on it, that dictation would need to be made available to the patient. Again, I'm not saying that I agree or think that this is a good idea. I'm just telling you what the ONC has put out in their information could constitute information blocking.
Okay, so we have a policy implemented to the patient that in which results take 1 to 2 weeks to come back. Is that acceptable?
No, that's a blanket policy that in and of itself is information blocking. So again, how quickly can those results be done? More than likely much faster than 1 to 2 weeks. So again, no delays. Okay, and I see the next one here. We have a policy. Let me see if that, okay. What is
Okay,
the definition? Go ahead.
what is the definition of a reasonable time frame?
Everything that I've read from the ONC pretty much says that a reasonable time frame is the same day. So now there could be circumstances where that's not reasonable for your office. You would want to document and put into a policy what is reasonable for your office and explain why it is reasonable. That way, if anything were to occur, you've got documentation that was created to explain your actions. Okay, Joe, oh, wait a minute. I don't see any more questions coming in. So if you want to wrap it up for us.
I would like to thank all of you for attending this webinar. Again, if you have any questions, feel free to email any of us, and we will be happy to respond to anything. If you would like to see the recording of this webinar, it will be posted to HIPAAcompliancekit.com by the latest Tuesday. And have a nice rest of your day.